welcome everyone to our first ever land partnership webinar with ICP Care. Our topic today is going to be life after ICP. So we're going to be talking about considerations for long-term liver health. What does it mean to be an ICP patient, and what does that mean for your liver health moving forward during pregnancy and even after pregnancy? So we have some wonderful panelists with us here today. And we're going to get started here in just a moment with our didactic from Dr. Iordache. But first, just some housekeeping items. So if you have a question and would like to raise your hand or throw it in the chat, you are welcome to do so. We will have a question and answer time at the end of our conversation here today. And then in the meantime, we just ask that people stay muted. If you would like to have your face on screen, you are welcome to do so. Otherwise, you can keep your camera off. We have no problem with that, but we'll just make sure that we're leaving lots of space for our presenters today as they're sharing their experiences with ICP and their expertise and their knowledge. And then we'll have plenty of time to have a full conversation at the end. So thank you so much, everyone, for joining us here today. So first, for our introduction, we have Lavinia Iordache, who is part of the University of Miami Health System. Lavinia Iordache earned her Master's of Clinical Medical Science from Barry University in Miami, and she has been a practicing physician assistant in the field of hepatology for the past 10 years. She completed a one-year fellowship at AASLD under the guidance of her supervising physicians, and she continues to provide care to a complex patient population in an academic environment. She previously attended medical school in her home country of Romania and graduated magna cum laude from Florida International University with a bachelor degree in biochemistry. She holds a NCCPA certification and is a proud member of several professional associations as well as the animal welfare organizations in Miami. Her dedication to helping people with liver disease extends to both inpatient and outpatient settings, and she has been expanding her clinical practice to include internal medicine as well as general gastroenterology. She values a holistic and patient-centered approach to care and is a big advocate for patient education, always striving to connect her patients to promote understanding of disease, build trust, and improve outcomes through collaboration. Lavinia is fluent in Spanish and particularly enjoys communicating with her Latino patient population in South Florida. She has a lifelong interest in learning different dialects and connecting with people of various ethnic backgrounds. In her free time, she particularly enjoys exploring new destinations and has a taste for adventure, unique art galleries, and museums. She loves cooking and entertaining, and she is intentional about pursuing holistic lifestyle through conscientious choices for a mindful integration of mind, body, and soul. Thank you so much, Dr. Iordache, for being with us here today. I'm going to switch over to your presentation slides really quickly if you would like to share a little bit about yourself.
Sure. Hello, everyone. Thank you so much for having me here. Thank you for that beautiful introduction. I didn't know you were going to read all of it. I just kind of sent whatever bio I had on hand. Yeah, I'm happy to be here. And I think the more interesting conversation is going to happen probably after my presentation. I've never presented for patients before, so I don't have that perspective. And, I'm so looking forward to listening to what everyone with a history of ICP will have to share from their perspective. So I'm happy to kind of go over some slides here, which I'm sure you're all experts already. But we'll go over some data together. All right, so intrahepatic cholestasis of pregnancy, right? So what is ICP? I wanted to start with this image, even though it has some typos that I found online, but I thought it really speaks to how the disease presents. And obviously, intense pruritus is the hallmark of the disease without a rash being present. Some patients may present with other manifestations like jaundice or steatorrhea, the fatty stools. Sometimes we can see some lab abnormalities in terms of like elevated liver enzymes, bilirubin. Sometimes you can see other manifestations as well, but it's important to also keep in mind that some of the findings on the blood work can actually be normal in pregnancy. For example, the low albumin or even alkaline phosphatase elevation. or alpha-fetoprotein elevation, which are happening not because of there's any underlying liver disease, but also because of the pregnancy itself, right? And it's they're being produced by the fetus and the placenta. The treatment is listed here, so this is just kind of at a glance. I really like the picture, so I wanted to start with that. So ICP, intrahepatic cholestasis of pregnancy, is the most common liver disease in pregnancy. Occurs in up to 2% of pregnancies overall, but it does have a higher incidence in certain populations. There's definitely a geographic variability. It is more prevalent in South America and in Northern Europe, Scandinavian countries. In the Arakanese Indians of Chile, it can go up to like a 27.6% in incidence. The etiology is multifactorial. There is definitely a correlation with the levels of estrogen during the pregnancy. But there's also genetic susceptibility and environmental factors. And I actually have another slide going a little bit more into depth about that. Pathophysiology, essentially decreased bile flow and accumulation of toxic bile salts into the skin, which cause the pruritus. We've already kind of gone over the elevated transaminases, and abnormal lipid panels sometimes can be seen, and increased risk for gestational diabetes. So this is a slide that I actually presented at GAP last year, and I think it sums up beautifully the etiology of this disease. It's not just one thing. It is driven by the hormonal factor, by the levels of estrogen, which explains why the disease occurs in the second and third trimester. It also occurs it's more prevalent in twin pregnancies because of the higher levels of estrogen. And it resolves right after the delivery of the placenta. However, we know that there is a genetic susceptibility in some populations, as we mentioned. There are some genes that have been involved, and they're listed here. ABCB4 is the more prevalent one, up to 16%, then ABCB11, and NR1H4, which encodes for the receptor FXR, which is, of course, the master regulator of bile acid homeostasis. And the genetic susceptibility is also evidenced by the fact that the disease actually it tends to happen in first degree relatives. So there's an increased risk there. It has a high recurrence rate in subsequent pregnancies. And, of course, there's familial clustering. And the environmental factors, it has to do with, I guess, not only geographic, but also seasonal variability. It's more prevalent in winter months, and it's associated with low selenium and low vitamin D levels, probably due to scarcity in the food supply. So going next, how does this happen? The pathophysiology is quite complex. This is a busy slide, but I guess the take-home point would be that there are 4 mechanisms by which the cholestasis occurs. There's a disturbance in the bile acid homeostasis. So the bile acids are basically synthesized in the liver from cholesterol. They're steroidal molecules, and they are eliminated in the bile through, together with the cholesterol and the phospholipids. And when this process is disturbed, it leads to accumulation of bile acids in the liver. So we have an increased production of bile acids, decreased metabolism, and inhibition of transporters. So essentially, I cannot point on the screen, but the estrogen up above enters the cell, it binds to the receptor, and then it downregulates the FXR, which leads to all of these processes. Then we have reduced membrane cell fluidity, also because of the estrogen, which increases the level of cholesterol in the membrane, making it harder for the bile acids to cross it. There's oxidative stress due to inflammation, release of cytokines, and also disrupted hepatocyte-tight junctions. So in essence, the bile flows freely into the cell, leading to toxicity. So all of that just to say that the pathophysiology is not completely understood. But we know what happens. We know how the disease presents, right? With the pruritus, we know that the bile salts accumulate in the skin. And this is essentially what we need in a way to make a diagnosis. I didn't have it on the earlier slides, but we do have to talk about how to actually make the diagnosis and what is pathognomonic for this condition. And I'll mention that in a little bit. So here I just wanted to basically acknowledge, all the changes, the metabolic and physiologic adaptations that have to happen during a pregnancy in order to accommodate the growing fetus. And the fact that this is a stressful time, as wonderful as it may be, on the human body, and at this time maybe underlying liver conditions could actually declare themselves, also the vice versa is also true. Women with a history of ICP tend to have an increased risk of a later diagnosis of some sort of liver disease, whether cholestatic or not, but the cholestatic seems to predominate. So here I wanted to kind of stop and acknowledge the breadth of liver diseases. So when someone presents with pruritus or whatever symptoms they may have, even in pregnancy, it is important to keep an open mind and to make sure that we are not missing maybe like an underlying condition that went undiagnosed. And of course, when we talk about cholestasis, elevated bilirubin, elevated bile acids, primary biliary cholangitis, primary sclerosing cholangitis, or the cholestatic liver diseases, the autoimmune hepatitis, sometimes some medications can present that way as well. So all of these can also be taken into consideration. Of course, there's others listed here: amyloidosis, sarcoidosis, patients with advanced cirrhosis who can have elevated bilirubin and other abnormalities on the blood work and who can present with itching. And there's then there's conditions associated with pruritus without a rash. And what comes to my mind is basically parasitosis or medications. Hydrochlorothiazide, opioids can present with pruritus. And also Hodgkin's, non-Hodgkin's lymphoma, HIV, and others. I'm not going to read through all of those, but yeah, differential diagnosis is important. So going forward, it is essential to remember that the complications for the mom are quite limited. I mean, yes, she presents with the pruritus and there is a risk there. However, the fetal complications greatly outweigh the maternal complications. So we're talking from intrauterine growth restriction to meconium staining to respiratory distress syndrome and arrhythmia, and also, of course, the most dreaded complication, which is stillbirth. So the initial management, we start with monitoring, right? We monitor the mom, and we'll talk about the treatment and what we can do to improve her symptoms. Essentially, we monitor the bile acid levels, and these are important. So first, you have to actually make a diagnosis of ICP by checking the bile acid level, which is not on this slide, I apologize. The bile acid levels need to be greater than 10 in order to be able to diagnose ICP. The higher the levels, the higher the risk, and probably the earlier that the fetus will have to be delivered. If you don't have a diagnostic bile acid test initially, however, the patient presents with pruritus, it is recommended to keep monitoring quite frequently. I would say every 1 to 2 weeks until you get the diagnostic level, in which case you can start treatment. Fetal monitoring is also important. It turns out that it can be done in 2 ways: via non-stress testing, or NST, which is basically a recording of the heart rate, which checks for accelerations, and biophysical profile, which is an ultrasound, which checks for fetal tone, for fetal movement, for amniotic fluid levels. And so it gives us information about the condition of the baby. Unfortunately, the monitoring has not been proven to decrease, or to prevent sudden death, in all cases. So when we talk about therapy, ursodiol is well known. Ursodiol is basically a naturally occurring bile acid that occurs in our bodies, right? And it basically competes with the toxic bile acids and allows for their elimination. So it is safe for both mother and the baby. We only start when we have biochemical evidence of ICP. So whenever we have that diagnostic bile acid level of greater than 10. The dose can go up to 2,000 milligrams per day. And it's important to mention it's based on symptoms and not so much on normalization of the liver tests. So, if the patient feels better on a lower dose, that's all we want to do. We don't want to chase normalization of AST or ALT. Usually the response is pretty quick. The decreased pruritus occurs within the first couple of weeks. So very low side effects, I would say. Sometimes some GI related diarrhea. Most patients tolerate it really well. And there are significant fetal benefits as well to taking ursodiol. It can reduce the risk of meconium staining. It protects the baby's heart and in general the baby's cells from damage due to the toxic bile acids. It restores the placenta's ability to transport the acids away from the baby. And I wanted to include here a couple of studies that were done with ursodiol. So PEACHES 2019 and 2021. Essentially, in 2019, they've done studies comparing ursodiol with placebo. And unfortunately, they didn't find a reduction in stillbirth, in premature death, in premature birth. However, in 2021, when they resumed the studies, and by the way, in 2019, we're not entirely sure. I mean, the study was greater, 3 times as large as basically all the other studies combined up to that point. However, in 2021, we are thinking that by using ursodiol, we are actually reducing the risk of premature birth. The stillbirth is still up for debate. It hasn't really been proven in all the cases, but there is an actual benefit to giving ursodiol for the mother and for the baby. So at a glance here, the mechanism of action basically relies on upregulation of the transporters during cholestasis. So there's going to be an increased transporter number amount in the transporters in the sinusoids, in the bile canaliculi, leading to improved cholestasis overall. So for refractory cases, I believe most patients respond really well to ursodiol, but there are some cases when ursodiol doesn't do the trick. We have a couple of options here. I like to mention cholestyramine because that's actually very well known for patients with liver disease, and it does work wonders for the itching. It decreases the ileal absorption of the bile salts, and it improves their fecal excretion. It's fairly well tolerated. Some GI effects have been reported, but it does work a lot. I mean, maybe the best for most patients for the itching. The dose up to 16 grams per day, but obviously we want to start slow to decrease the side effects. S-adenosyl L-methionine or SAME. It's a glutathione preceptor, which basically increases membrane fluidity. So estrogen on one side increases the cholesterol and decreases the fluidity. This will increase the fluidity and will allow for the bile acids to be eliminated. It's difficult to administer because it's an IV medication. So unless the patient is admitted for intractable pruritus or for other complications of liver disease or other reasons, then it's going to be difficult to administer. Rifampin, we have very limited experience in pregnancy. It can be used in conjunction with ursodiol, but really less than 30 patients have been studied on that, to my knowledge. And vitamin K does nothing basically for the bile acid levels. It's only given because of some malabsorption issues, or for patients who are cirrhotic, decompensated maybe, or coagulopathic, and is given for that reason. So for the postpartum course, I included here just a few kind of bullet points. High recurrence rate up to 70%. Pruritus usually resolves within a couple of weeks after, within a few days actually, after normalization of the bile acids and the liver enzymes. If the liver enzymes do not normalize immediately, or in a couple of weeks, I would say, then you would want to do further workup and make sure we're not missing anything. Dialysis continued when the labor begins. Small amounts have been detected in the breast milk, but they are not known to cause any harm to the baby. So breastfeeding is usually encouraged. I'm curious to see what the OBGYN providers think about that. And there's also some debate, I guess, on the estrogen progestin contraceptives, as they may be causing some recurrent cholestasis in patients with a prior history of ICP. So we generally use caution in those cases, but I believe the incidence is quite rare. Again, I'm very curious to hear firsthand stories. I included this slide because I think there's also some concern for how the ICP may impact the liver long term. And we know that it resolves right immediately after the pregnancy. It shouldn't leave any long-term consequence. This is not like a chronic liver disease. It's usually self-resolving after pregnancy. However, it can be kind of like the hallmark, if you will, of more things to come. Certain conditions can occur later in life, ranging from any other cholestatic liver diseases, cholangitis, maybe primary biliary cholangitis or sclerosing cholangitis, gallbladder disease, others like pancreatic, diabetes, other autoimmune conditions like thyroid disease or Crohn's disease, and cardiovascular if preeclampsia was present. We are not thinking that the ICP is actually the trigger for these conditions. We are suspecting that whatever risk factors the patient had to begin with that put the patient at increased risk of developing ICP, those are the risk factors that will be involved in development of these liver conditions. And children, as a side note, children born to women with ICP, there has been some data showing that there are at increased risk of developing metabolic syndrome by the age of 16. However, with the use of ursodiol, those risks are apparently quite well mitigated. So long term, there's no a real problem with the health of the liver for these babies. And another, like a few key points at the end. Let me see. I feel like some things I've repeated on a couple of slides there. So the persistent elevation of the liver enzymes is important to trigger further workup. Maternal prognosis is benign. Yes, if there's any concern for hepatic encephalopathy, for liver failure, if the INR goes up, or if we're seeing any signs of decompensated liver, that's not going to be a direct consequence of ICP. It's usually something underlying, so we should rule out alternate etiologies. High recurrence in subsequent pregnancies. And as long-term preventative care for liver disease, I don't think we have anything in particular for patients with ICP other than we would advise just the general population. Avoidance of obviously toxic substances. We like to recommend against a lot of herbal supplements, which I'm on the fence on, right? Because there are so many of them that are beneficial for so many things out there, as we find out. However, for the liver, it's important to monitor at least the liver function, because some of them can cause toxicity, even though they're natural. We know what that means. They're not FDA approved, and we don't have the complete information on those medications. But yeah, not excessive alcohol, maintain a healthy lifestyle, minimize the risk for diabetes and metabolic syndrome in general. And this is, I believe, my last slide. Basically, everything's on here. It's great. It's from ICP Care. It talks about the bile acid levels and the fact that bile acid over 40 correlates with like a severe disease. And that's when we see most of the complications, the increase in the fetal complications and so on. So the treatment that we discussed, we also have to consider early delivery for patients with ICP. Usually between 36 and 39 weeks, even earlier in the severe cases, especially with intractable pruritus, because that's where the increased stillbirth risk happens. So usually patients are scheduled for C-section anywhere between 34 and 36 weeks. Of course, steroids for lung maturity for a delivery before 37 weeks. And I believe that is all that I wanted to say. Let me know if there's any questions or anything. I don't know if I'm on time. Sorry. I feel like
you absolutely are. Thank you so much, Dr. Iordache.
No problem. You can call me Lavinia.
Thank you, Lavinia. So we'll take some questions after we go through our patient experience conversation. But Lavinia, if you have the ability to answer questions prior to hopping off here, I don't know what your time frame looks like. Does anyone have any quick questions? Because I know that Lavinia needs to hop off and return to her patients, which is always admirable.
I know I'm going to speak in a couple of minutes, but I'm Laura Bonebreak. I'm with ICP Care, and I am the OBGYN. So I loved this talk. This was amazing. Thank you so much. And I love how you use the word reveal. We'll talk about that a little later, kind of when I talk about kind of my personal history. But I guess the question that comes up a lot, and if you could just touch on it a little bit, I think you did. But I think people family planning comes up a lot. Should I have another ICP pregnancy? And so I think you kind of touched on this, but I think a fear in our community is another pregnancy will damage the liver more. I didn't know if you could touch a little bit on that really quickly before you had to hop off.
Yeah, sure. Thank you. So I don't think the ICP damages the liver even the first time around, right? So, it's a reaction that we see, right? Patient presents with the pruritus and everything, but it doesn't necessarily damage the liver. And the liver is actually quite resilient. So we know even from patients with like more chronic liver disease, the liver does regenerate, right? Once you make all the lifestyle changes and the liver has an opportunity to regenerate and the fibrosis can reverse. So the fibrosis in the liver ranges from stage 0, right, nothing, to 1, 2, 3, 4. When it gets to 4, we call it cirrhosis. So anywhere between stage 1 and 3, the fibrosis is fluid, so it can progress, it can regress, right? So I'm not aware of the ICP actually causing any liver damage. It's just the presentation, and it can be addressed, and the risks are more for the fetus than for the mom. Obviously, we don't know what happens, right, if we just never treat the mom, right, because that's not acceptable. And for the subsequent pregnancies, the same thing would happen essentially. I believe it tends to happen a little bit sooner in the pregnancy with like a second or a third pregnancy. But by then you're already aware, you're being closely monitored, and the treatment would be essentially the same. Yeah, so I don't think there's any evidence to support that there's going to be a liver problem long term because you're having 2 or 3 pregnancies with ICP versus just 1. Does that help?
Yes, thank you. I agree. I just wanted you to connect. It's good to hear someone else clarify as well. So yeah, thank you so much. So yes, yeah.
If you have time for 2 more quick questions, Lavinia, that would be great. We have one question. Oh, sorry, go ahead. Are we good to take 2 more questions?
Yeah.
Okay, perfect. So we have one from a participant that says, I'm 13 months postpartum and still breastfeeding with continued high LFTs. Could breastfeeding lead to high APs and GGTs?
So the alkaline phosphatase, yes, those are markers of cholestasis, so to speak, but the breastfeeding should not be a part of that. Breastfeeding shouldn't influence the liver enzymes. So 13 months postpartum, by then we should have seen normalization, right, of like the liver enzymes and everything. I would say, I don't know if she has any symptoms, if there's anything else going on, right, with the liver. Sometimes even like a fatty liver will cause elevation of the alkaline phosphatase. The GGT, we know that it's a cholestatic marker, but also, with alcohol, which I'm not assuming that this is the case here, but just I wanted to throw it out there. But yeah, I'm not aware of an association with breastfeeding. I don't think breastfeeding should cause any liver enzymes abnormalities. So I would work that out, in due time.
Thank you for your response. And then our second question that we have is there any evidence of a connection to COVID-19 infection or a higher incidence of occurrence if someone contracts COVID while pregnant? Both my sister and I developed symptoms 10 to 14 days after contracting COVID.
So I apologize. I'm not aware of a correlation between ICP and COVID or the presentation of ICP and COVID. However, we had many cases of what we call COVID hepatitis, patients with like a significant liver damage, even liver failure. I remember seeing cases here while I was working inpatient, and it was just like a very sad and sudden presentation in a lot of patients, which, in most of the cases, there were some comorbidities there, some obesity, some diabetes, something else, but they had a severe liver involvement with basically jaundice, bilirubinemia of like 20, and essentially liver failure, liver enzymes in the hundreds and the thousands. So, but those patients were also very sick. So COVID hepatitis is a real thing. We know that. And I think it can happen even now in some patients. But so I wouldn't be surprised if there was an association there, between the presentation of the ICP and the COVID.
You for that. And then we know that we have to let you go so that you can get back to clinic. So thank you so much for being willing to join us today and for providing your expertise on ICP. It's really helpful for us all to be exposed to that research and know what's going on as we're developing more awareness of it. So thank you so much, Lavinia.
Thank you so much for having me. It was my pleasure. I want to stick around for as long as I can. I'm waiting for some patients to be checked in here, but I'd like to hear some of the stories from our patients who I believe they're present here, right? And they're going to be sharing some information. So I'm very curious to see what their perspective was. But thank you for having me. It was my pleasure.
Thank you. Yeah.
So we are going to move on to some patient conversations now. I am so happy to introduce Donna. We have been developing a relationship here at GLI with ICP Care, and so being able to partner with other organizations and bring awareness to rare liver diseases and chronic liver diseases alike, we are so happy to be able to provide folks with education and really move the needle towards more positive liver healthcare outcomes. So I'm going to give Donna's quick bio here, and then she's going to share a little bit about her story and her experience with ICP. So Donna is a passionate advocate of intrahepatic cholestasis of pregnancy with a mission to save babies' lives. She's the founder and chair of ICP Care, a 501c3 nonprofit, an organization focused on helping families from experiencing the loss of their baby from the stillbirth risk of ICP and increasing awareness of ICP globally. Her firstborn son, Jordan, passed away due to intrahepatic cholestasis of pregnancy, ICP, at 37 weeks. She experienced ICP with all of her pregnancies and is blessed with 2 healthy boys, Brayden and Evan, and an angel baby. She is a passionate advocate and storyteller who is making a massive impact in the lives of those affected by ICP. So without further ado, Donna, please go ahead and take the floor.
Thank you so much. I appreciate GLI and everything that you're coordinating, partnering with. It's just amazing. I really appreciate everything. So just to touch on what you said, my passion and my drive throughout the years has been to really help other families from experiencing the loss of a baby from stillbirth risk. As you mentioned, and as you shared already, my firstborn son, Jordan, passed away due to ICP 22 years ago. And I began to feel an intense itch during my third week of pregnancy. Other than that, I had been healthy as can be. And honestly, nobody in my family, my mom or my sisters or anyone really that I spoke to ever thought, itching in pregnancy would be something to worry about or like a red flag. In my pregnancy, I was diagnosed at 36 weeks, which was rather late. I had high bile acid levels, and unfortunately, he did pass away during my 37th week of pregnancy on June 10th. This was back in 2003. I wasn't prescribed Urso back then. Again, this was 22 years ago. It was not as much as known about management and as it is today. So it's come a long way, and it's just amazing to see the progress and everything that's available, resources, and just awareness for families that are out there looking for help, questions answered. So based on my research back then and my past experience and the expertise of my doctors, I was convinced that continuing my monitoring of non-stress tests with Jordan and early delivery that we had already talked about, he was going to be born at 38 weeks. I was convinced, that he would be okay, he would be safe. But I soon learned that ultimately, the truth of a lot of some itchy moms that they face, to this day that, back then, 22 years ago, it was quite different. Just not all healthcare professionals were necessarily up to date or really knew exactly how to manage. In my case, I had really high bile acid levels. So in other words, I should have been, induced sooner. So after my loss, I did go to a gastroenterologist because I was obviously quite traumatized and concerned because I had been very healthy. And I did know that my dad had liver issues, but it wasn't anything severe. And so I did have additional blood work with my gastroenterologist to rule out any underlying liver issues. So the results all came back normal. Thankfully, nothing happened. And then I experienced ICP again with my second and third pregnancies in 2004 and 2006 with my son, Brandon and Evan. So I was seen by a maternal fetal medicine specialist. So these were high-risk pregnancy doctors that really knew how to be able to treat and manage the high-risk pregnancy, which is ICP. Thankfully, my boys were born healthy as can be at 36 weeks induction. And then just to touch a little bit about after my pregnancies with cholestasis pregnancy, I had checked my bile acids and liver function test to see if everything was okay about 6 weeks after pregnancy, and everything was fine. I did have somewhat of itching return during my menstrual cycle, during ovulation and all that, which is fairly normal. And then when my sons, I want to say, were about 6 and 7 years old, this was back in about 2010, I began to have right upper quadrant discomfort pain. And actually, I had never experienced that during pregnancy, during my ICP pregnancies, which is and can be a symptom that does occur. So I was concerned, and I set a scheduled appointment with a hepatologist, and I went in just to rule out, again, anything that was going on. So he suggested me to have a pipida or a HIDA scan on my gallbladder. So I had that scan done, and it came back mildly dysfunctional. He did not recommend me to have my gallbladder removed. I did not have any gallstones or sludge or anything. And thankfully, the fight for quantum discomfort wasn't that terrible. I found like during my menstrual cycle, it would flare up, depending on where I was during that time. And sometimes it would be really, really bad. I'd have to lay down and put pressure on my right side and just, be very mindful of what I was eating, because sometimes that would flare things up as well. But besides that, I've been healthy. Every year I have my annual, I have liver function test done, and everything's normal, thankfully.
Thank you so much for sharing your story. I know that being able to talk about previous experiences can often be difficult, so I really appreciate you being able to take the time and share that with us. So then we have the pleasure of hearing from two separate patients, both of who are ICP warriors. And so we're so glad to also have with us Dr. Laura Bonebreak, who has attended our Advanced Advocacy Academy and is someone that we have a really close relationship with, and we're very glad to be able to collaborate with her on a regular basis. So Dr. Laura Bonebreak is an OBGYN who treats pregnancy disorders, including ICP. She also has she has had 4 ICP pregnancies, which she feels allows her to better understand what patients face with this disorder. She currently serves on the board of directors for ICP Care to help spread awareness and advocate for patients with ICP. So Dr. Bonebreak, we would love to hear your experience and kind of gain some more insight as to what it looks like when you do recognize that ICP might uncover an underlying liver disorder.
Yeah, thank you so much. I'm so happy about this webinar because this has been kind of a passion of mine to kind of bring forward some awareness a little bit about kind of ICP and lifelong. So as she said, I'm an OBGYN, and I had my first pregnancy when I was still in residency training. So I had heard of ICP, had maybe a patient or two with it, but I was 23 weeks pregnant when I started having severe itching, and actually was diagnosed with ICP fairly early in that pregnancy. So that was my first journey with ICP. And then I have since had ICP with my other 3 pregnancies. What's a little different about my ICP is I am a kind of an early onset ICP. So I think partially the recognition in my future pregnancies, I could tell the signs earlier. My itching starts between my fingers. I always feel it between my fingers. And so in my last pregnancy, I didn't even have a positive pregnancy test before I started itching. So I started itching and I called my OB, and my bile acids were elevated at 4 weeks. So that started kind of a red flag in the eyes of my maternal fetal medicine high-risk specialist and my OB. There are some case reports of early onset ICP, but not a lot. It's definitely more common in the 2nd and 3rd trimester. So that started their kind of wheels thinking and my wheels thinking, could there be something else underlying? So in my 3rd pregnancy, with my levels being really high in the 1st trimester, I was sent to a liver specialist, a hepatologist, who did a whole panel of blood work during the pregnancy and actually discovered that I carry a gene for something called alpha-1 antitrypsin. So I also have what's called alpha-1 antitrypsin MZ. It used to be known as a carrier state. It's now known as kind of a co-founder, where you don't have quite as severe disease as someone who has 2 genetic copies. So I discovered that through my ICP pregnancies that I did have something underlying. And so I'm always one to push for, especially in early onset cases, severe cases where bile acids are greater than 100, or if you have multiple family members with ICP, multiple family members with gallstones needing their gallbladder removed, or liver issues, that you really should push to have some blood work done, ultrasound of your liver, just kind of make sure there's nothing else going on. Ultimately, luckily, my disorder, as long as our presenter was discussing, as long as I stay healthy, I should be fine. So healthy lifestyle, healthy diet, managing to make sure to prevent fatty liver, staying a normal weight, and definitely avoiding smoking. There is a liver-lung connection as well with some of these disorders. And so that's been kind of my passion, to kind of get that word out that ICP doesn't always, well, ICP itself, it's a misnomer. ICP itself ends, you're done with the intrahepatic cholestasis of pregnancy part, but as we learned today, it could reveal something else that was kind of sitting there all along. So yeah, that's my story. So yeah. So.
Thank you so much for sharing, both of you. I so deeply appreciate your willingness to put yourself in front of folks and talk about something that is still relatively unknown, but you have that awareness and that knowledge that this is important and it needs to be talked about. So I so deeply appreciate all of the team at ICP Care, but especially being able to work with Donna and Laura has been a catalyst for my advocacy. So I appreciate you both so much. So we are going to move into a short Q&A time. We had lots of really good questions already. And so we'll take questions right up until about the last 5 minutes. And then we'll kind of wrap up after that. So I have a question here that says, can the dose supplement help regenerate the liver? And if so, can you take it while pregnant? So if Laura or Lavinia or Donna has any information on that.
What supplement? Sorry, D-O.
Says the dose supplement.
I guess I'm not aware of what. Are you aware of what the dose supplement is?
We've actually had some patients come to us and they were taking those supplements and they actually had toxicity to the liver. I remember
Okay.
and like he was in his 40s and he was doing the dose for whatever health benefits. And I don't know if it was a bad batch or whatnot, but like I said, you know, sometimes we do worry about the most benign things with the liver. And we always ask about any or over-the-counter herbal supplements that patients might be taking whenever they present with liver enzymes elevation, because that might very well be the culprit. So we are generally, you know, very cautious with that. We say, don't take anything that you don't absolutely need. And if you do, you have to monitor your liver really closely, meaning somebody should be ordering some blood work every 2-4 weeks, let's say, and see if you tolerate it and always kind of take a break. If you're going to take that for a month, give your liver a break for another month or so, because you're essentially putting more things into your body that the liver has to process. So I don't know about regeneration and all of that. We know the liver regenerates on its own as long as it's not overloaded with, you know, the obvious, right, like the alcohol or whatnot. And, you know, I think the supplements kind of play a role here too, because you're essentially making the liver work harder. There's no actually data on, like, for example, milk thistle, which I know is all over Google, that, you know, patients come to me all the time and they say they've been taking milk thistle because they read that it's good for the liver. There is no data to even support that milk thistle does anything, any benefit. We generally say it's okay to take. It hasn't been proven to cause any harm either. So certain things go like that. But as far as those, I know for a fact that it can cause toxicity. So I'm not going to say that it helps regenerate the liver because, you know, of course, our bodies work in mysterious ways. So.
Yeah, I'm getting a lot of questions too about are there any supplements that you would recommend? So a lot of questions about whether prenatal vitamins cause any issues, whether or not things like turmeric, milk thistle, like you just mentioned, or dandelion, or if there are any things that would be beneficial as far as supplements go for anyone who is suffering from ICP.
No, like not even for ICP or the general population. I don't think, you know, I think a multivitamin is okay. I think prenatal vitamins are most likely to be okay unless, you know, the formulation of that particular vitamin doesn't do well with your body and with the way the liver metabolizes it. But most of the time, we are perfectly fine with patients taking vitamin D. You know, everybody's vitamin D is low, or magnesium for muscle cramps, or, you know, things like that, like obvious things we're okay with. Vitamin E has this anecdotal role in liver disease. Again, we don't really have very robust data to support the use of vitamin E. It's sometimes being prescribed sort of for fatty liver. We generally recommend not taking more than 400 units, international units per day. So 800 international units has had some correlation in older patients with, for example, in older men with prostate cancer. Again, we don't really have like a full data on that, but there's a risk there. So 400 units is all that you should be taking if you are taking vitamin E. But other than that, even like I mentioned, milk thistle, we don't really have data on that. So we'll never recommend to someone, oh, you should start taking this. Most of the time they come to clinic and we say, okay, so you've been taking it for 6 months. Your liver enzymes are normal. Fine. I'm okay with it, but in terms of like what it actually does, I think mostly the diet, the exercise, the lifestyle changes is what's going to have like a long-term benefit. And most of the time they start with liver enzymes elevation, even so mild, and then they go on all the lifestyle changes and they make all these changes to the diet and the lifestyle, and then they also start taking the vitamins and they think it's the vitamins, but really it's actually everything else that you're doing. So I'm sorry.
Thank you for providing clarity on that. I appreciate it. We've got a question that said, is there any research on a relationship with the H63D variant?
With ICP particularly, not that I'm aware of, So we know it's funny that Dr. Donna, I'm sorry, I don't remember her last name. She mentioned the association with alpha-1 antitrypsin. So that's one that we know. I mean, we've had patients with alpha-1 antitrypsin deficiency and basically nothing else. And it was biopsy proven that that was the cause of the liver disease. Most of the time, we'll find some variant of the phenotype, which may contribute to some extent to the liver disease, but most of the time there's something else underlying. H63D is one of the mutations for hemochromatosis, but it's only one. It's basically the second most important one. And it all depends, right? Are you a carrier? Do you have both genes? In which case, maybe you would have like a predisposition to having iron overload in the liver. But in terms of like correlation with ICP, I mean, I would assume any liver condition, right? If you have an underlying liver condition, you're more predisposed of developing another liver condition, and ICP is part of that. So, but I don't have like any particular data on that.
We have a question that says, my sister, aunt, and I all had our gallbladders removed, and I have an uncle with biliary cancer. I had my gallbladder removed prior to my ICP pregnancy. My bile acids were fairly low, just above 10. What type of testing do you recommend I do? Do you recommend seeing a primary care provider or a specialist?
So the gallbladder was removed, right? And seeing a specialist for because of the family history of biliary cancer.
Yes.
So, okay, so the gallbladder, I mean, she might have been symptomatic, right? And that was the cause for removal. Otherwise, I wouldn't recommend cholecystectomy, if you're not symptomatic or there's no concern there. I know for like pancreatic cancers, there's definitely a role for genetics. And we do have, like at the University of Miami, we have genetics clinics and patients get referred all the time to, depends on the extent of the family history and all of that. So I think, biliary cancer, was it like a cholangiocarcinoma? Was it like a liver cancer, but of like the cancer of the bile ducts? Was it pancreatic? Because they're all kind of tied in together sometimes. So I would definitely see maybe a gastroenterologist, to begin with, or hepatologist if there's access to one in the area. Just for like an evaluation given the family history, and then go from there. Sometimes they do refer to genetics, but as far as like continued monitoring, I don't know. In the absence of symptoms, I'm not sure that would be indicated. Sometimes they do order MRI. Again, like it all depends on the risk factors and what genetic mutations they might find or not. They might order like an annual or biannual MRIs and things like that.
Question. And then I just wanted to let everyone know that I really appreciate the amount of discourse that we're having regarding this topic. It's really encouraging to the future of awareness of ICP. So if there are any questions that go unanswered, Lavinia has been so gracious as to provide additional information after the fact. So if there are any questions that, like I said, go unanswered, I'll be able to send her those questions, and we'll be able to get an answer sent out in that email that I was just mentioning for access to resources afterwards. So just to make sure that no one feels like their questions are going unseen, we see you and we want to make sure that we're providing that information, but we're running out of time, unfortunately. So the last question, oh, go ahead, Dr. Bonebreak.
And I was just going to say too, part of our website, we do have an after pregnancy page. If you guys haven't found it, we have one for both patients and providers. So the patient one is kind of just goes through it for just kind of basically. And then we actually have a page for providers that goes deep into basically the studies that are out there. There's not a ton out there. We're starting to get more, but it goes through risks of all the questions you might have today. Can I be on birth control? Can I be on hormones? What are the risks to my children? And when should I think about further screening? So we do go through the literature that is out there. We have a page on our website at icpcare.org. If you, the in-depth one is going to be under the provider tab. You'll find the after pregnancy. And if you do want to do further reading, if you have a subject you're interested in, we do have a link citation to a lot of further articles if you want to do a deeper dive into anything you're interested in. So that's definitely a resource. I wanted to make sure that we do have things for after pregnancy. So, yep. So.
Thank you, Dr. Bonebreak. I really appreciate that. I love being able to point folks to resources, and I know that ICP is really great with that. So thank you so much for providing that information. So the last question that I have here, and I know that this is a great topic for both you, Dr. Bonebreak, as well as you, Lavinia, but as far as kind of like standards of practice go, I have a question here where someone is mentioning that they had some issues where after their pregnancy, they weren't necessarily getting as much monitoring of their enzyme levels as maybe they thought they might have needed. So the question we have is, I'm curious if anyone else has had a similar experience with non-normal levels of enzymes after pregnancy, and if we know if there's any action being taken to revise the precedent for retesting liver function after delivery.
So it's touched on briefly in the SMFM guidelines. So luckily a few years ago, up until a few years ago, we had a one-page guideline from the societies in the United States. And so luckily we do have some nice guidelines. And they do touch on that, but there is not a standard. So there's not something that says the OBGYN should check your, it's basically very vague. So they left it very vague. Just that you should have your levels tested at some point postpartum. But yeah, there is not a standard guideline. Which is why we like to raise awareness, especially in people with those early onset, those high levels. Definitely just seeing that those bile acids versus liver functions go back to normal. And I will mention also something that I learned through my pregnancies is you do want to make sure that they're also checking an alkaline phosphatase. So if you are going to have labs done postpartum, to see if they go back to normal. You don't just want them to check the AST, the ALT. Those are the two kind of liver enzymes. You want them to do a full, what's called a CMP, or make sure that alkaline phosphatase is on there, because that is an important one that is elevated in pregnancy from the placenta, but can also be elevated in PBC and kind of other disorders. So you do want to make sure that one goes back to normal as well. But there is not a ton of strict guidelines, just like the mention that we should consider it. So.
Add, Lavinia.
Yeah, I don't think I have much to add to that. I mean, in terms of like guidelines, I would assume everybody who's going through this, right, they would seek, an evaluation at some point, right? Like not maybe in the first month of the pregnancy if they're asymptomatic, but at some point, yeah, you should have a follow-up and make sure that everything is, of course, after pregnancy, I would say, yeah, for sure, like the first couple of weeks monitoring, but like after that, right, like once everything resolves, I think that was the question, when do you go back and I would absolutely have some blood work done with the primary care at least to make sure the liver enzymes are normal, and then go from there to see. I think most patients are very proactive though. Once they have some sort of diagnosis of liver disease, we get a lot of patients who come for a follow-up, even if they have just like a little cyst or something, and they are reassured that it's benign. They will follow up at 1 year. They will ask for another ultrasound and things like that. So definitely, 6 month, a year follow up, even if you don't have symptoms, for sure.
Well, thank you so much to our phenomenal panelists for providing us with deeper insight into ICP and bringing more awareness into this space. We so deeply appreciate every single one of you. And thank you to all of you for attending today. Advocacy starts when we start to educate ourselves. And so I really deeply appreciate all of your participation, all of your questions. Please be on the lookout for an email regarding any follow-up from questions that might not have been answered, as well as information on where you can access the recording for this webinar today. So thank you so much for taking your time out of your day to join us, and everyone have a great rest of your Tuesday.